Welcome back to the deep dive. Today, we're tackling a really big one. For you, the learner, looking at Unit 8 in, Lily's pharmacology text.
Yeah.
It's a lot. We know you're facing some critical material here, dealing with, well, life and death stuff, managing cell growth, and the immune system.
That's right. It's a dense unit. We're essentially trying to condense 5 really complex, high-stakes chapters. We've got chemotherapeutics, biologic response modifiers, immunosuppressants, and immunizing drugs.
Yeah, a huge amount.
And our goal isn't just to, read off definitions. We want to help you turn this information overload into practical knowledge you can actually use safely. So we're pulling out the key safety patterns, the must-know mechanisms, the things that really connect these different drug classes.
And the core idea running through all of this, it's pretty profound, isn't it? It's this whole spectrum of manipulating the body pharmacologically. We're looking at, all-out chemical warfare against cancer cells.
Right, eliminating those rapidly growing cells.
But then also the really fine-tuning needed for the immune system, calming it down in autoimmune disease or for transplants.
Or boosting it, enhancing defenses with vaccines.
Exactly. It's like a continuous line from maybe blunt force killing of cells to really precise molecular targeting.
It is. It covers a vast range of interventions.
Okay, so let's start with the heavy hitters, the cytotoxic drugs. But before we get into how the drugs work, maybe we should define the enemy, malignancy itself.
Good idea. Cancer, fundamentally, it's about cells losing control. They grow uncontrollably, they don't differentiate, meaning they don't mature into specific, useful types of cells.
They just stay generic and keep multiplying.
Exactly. And then they invade nearby tissues. And the really defining characteristic of malignant or cancerous tumors is metastasis. That's the spread.
Spreading to other parts of the body.
Right, from the original site to distant locations. We might use terms like tumor or neoplasm, but it's only the malignant ones that invade and metastasize. Benign tumors don't do that.
And the book stresses, Lily stresses, that cancer isn't just one random event. It's a process, right? A series of steps.
Absolutely. The carcinogenesis model lays this out. It starts with initiation, maybe a mutation from a carcinogen. Then promotion, these mutated cells start multiplying, expanding.
Okay.
Then conversion, where more genetic changes happen, making them truly malignant. And finally, progression, where they gain the ability to invade and metastasize. Chemotherapy often targets cells at different points in this whole sequence.
Which is why combination therapy is so common, I guess.
Yeah.
Hitting it from multiple angles.
Precisely. You target different vulnerabilities in that progression.
So that progression leads us to the big challenge for traditional chemo. The cell cycle. These drugs have to mess with the cell's life cycle somehow. Can you walk us through those phases again? They're pretty critical.
Definitely. Think of the cell cycle as the cell schedule for dividing. It starts in G0, that's the resting phase. Cells are just hanging out, not actively dividing, but they could.
Okay, dormant.
Sort of. Then comes G1, the first growth phase. Then S phase, this is super important, where the DNA gets synthesized, copied. Then G2, where the cell preps for division. And finally, M phase, mitosis, the actual splitting into 2 cells.
G0, G1S, G2M.
Got it. And the drugs, they work differently depending on where the cell is in that cycle.
Exactly. That's a key distinction. We have cell cycle-specific drugs, or CCS drugs. These guys only kill cells that are actively in a specific phase, like an S-phase drug stops DNA synthesis, an M-phase drug stops the actual division.
So they work best on cancers that are dividing really fast.
Yes. Tumors with a high growth fraction, lots of cells actively cycling. Then you have the cell cycle nonspecific drugs, CCNS. These are cytotoxic in any phase, even that resting G0 phase.
Ah, so they can hit the dormant cells too?
They can, which makes them useful for slower growing cancers as well, but they're generally less selective, you could say. They hit resting normal cells too. That makes sense. So oncologists might use a CCNS drug to hit the bulk of the tumor, including resting cells, and then a CCS drug to specifically target the ones that are actively dividing.
That's a very common strategy. You try to maximize the cancer cell kill, but you often increase the side effects, the toxicity, unfortunately.
Okay, let's unpack some of these CCS drugs then, starting with the antimetabolites. You called them tricksters before.
Yeah, I think that fits. Antimetabolites mostly work during the S phase, that DNA synthesis phase. They're basically lookalikes.
Lookalikes?
Yeah, they're structurally really similar to the natural molecules, the metabolites that cells need to build DNA and proteins. Things like folate, purines, pyrimidines, the building blocks.
So the cell gets cooled.
Exactly. The cell tries to use the antimetabolite instead of the real thing, But the fake block, the antimetabolite, it gums up the works. It stops the DNA or RNA chain from getting longer or inhibits key enzymes. So no new DNA, no new proteins, cell death.
And the big example here is methotrexate, which has that really critical safety alert because it's used for other things too,
It
right?
gets absolutely critical. Methotrexate is a folate antagonist. It blocks an enzyme needed to use folic acid. Now, in high doses, it's a cancer drug. But in low doses, it's also really effective for autoimmune diseases like rheumatoid arthritis, RA, and psoriasis because it suppresses the immune system.
Right.
The danger point, the absolute must-know, is the dosing schedule for RA. For rheumatoid arthritis, methotrexate must be given weekly, usually just once a week.
Not daily.
Never daily for RA. If someone takes the low RA's dose every day by mistake, the cumulative effect is devastating. Fatal bone marrow suppression, severe gut toxicity. You, as the clinician, have to verify that schedule weekly for RA every single time. No exceptions.
Wow. Okay, so dose and schedule make the poison here.
Perfectly put. Now, another antimetabolite, cytarabine, often used for leukemias, has its own unique issue. Cytarabine syndrome.
What's that?
It happens pretty fast, like 6 to 12 hours after getting the drug. Fever, a specific kind of rash, muscle pain, bone pain. It can look like a bad infection or allergy.
So you need to recognize it quickly.
You do. The good news is it can often be prevented or treated effectively with corticosteroids given beforehand.
Okay. Moving through the cell cycle, we hit the M phase, mitosis. And the drugs here are the mitotic inhibitors. Plant-based?
Often, yes, like the vinca alkaloids from the periwinkle plant and the taxines from the yew tree. These drugs basically jam the cell's division machinery.
How do they do that?
They mess with microtubules. These are tiny protein strands that form the mitotic spindle the structure cells use to pull the copied chromosomes apart during division. Vinca alkaloids, like vincristine, stop that spindle from forming properly, so mitosis just halts in the middle in metaphase.
Okay. And this brings us to probably the biggest safety alert in the whole unit. Vincristine, the administration route.
This is paramount. Vincristine is really valuable because it hits cancer cells hard, but strangely, it doesn't suppress the bone marrow as much as many other chemo drugs. Its main toxicity is nerve damage, neuropathy.
Right.
However, if vincristine is accidentally given intrathecally injected into the spinal fluid,
Oh, no.
it is almost always fatal. It causes a rapidly ascending paralysis, neurotoxicity that moves up the spinal cord. It's one of the most catastrophic medication errors possible in oncology.
That's terrifying. What's done to prevent this? There must be strict rules.
There are. Very strict. National guidelines mandate specific protocols. Vincristine should never be prepared or administered in a syringe because syringes are often used for intrathecal injections.
So how is it given?
It must be diluted in a small IV bag, usually like 25 to 50 milliliters of fluid, and that bag must be clearly, prominently labeled. For intravenous use, only fatal if given by other routes.
Ah, so the different format, a bag versus a syringe, acts as a physical safety check.
Exactly. It makes it much harder to make that fatal mistake. Vigilance here is just non-negotiable.
Absolutely vital information. Okay, one more CCS class, quickly. The topoisomerase I inhibitors, topotecan or inhibican.
Right, these work back in the S phase again. Topoisomerase I is an enzyme that manages the twisting and untwisting of DNA during replication. It snips the DNA, lets it unwind, and then sticks it back together.
Kind of like untangling a knotted phone cord.
That's a great analogy. These drugs, topotecan and irinotecan, they let the enzyme make the snip, but they block the sticking back together part, the relegation.
So the DNA stays broken.
Exactly. It leads to permanent DNA strand breaks, triggering cell death.
And for irinotecan specifically, there's a major side effect concern: diarrhea.
Yes, and it can be incredibly severe. Irinotecan causes two types. First, an early acute cholinergic diarrhea happens quickly, needs atropine immediately. Second, and often worse, is a delayed diarrhea, heating 2 to 10 days later.
And that needs serious management.
Aggressive management. Standard loperamide doses aren't enough. Patients often need a high-dose protocol, like 4 milligrams up front, then 2 milligrams every 2 hours until they're diarrhea-free for 12 hours. If you don't manage it aggressively, it can lead to life-threatening dehydration and electrolyte problems very fast.
Okay, let's shift gears now to the cell cycle nonspecific drugs, the ones that hit cells even when they're resting in G0. This is where we find some of the real old-school chemo agents, right? The
Mm-hmm.
alkylating drugs.
Yes, these are among the oldest and frankly some of the most powerful chemotherapy drugs we have. This class includes the classic nitrogen mustards like cyclophosphamide and also the platinum compounds like cisplatin.
And how do they work? Alkylating sounds chemical.
It is. They work by transferring an alkyl group a specific chemical structure directly onto the DNA molecule. This causes damage, particularly abnormal links or cross-links, between the DNA strands or within a single strand.
So it messes up the DNA structure itself.
Fundamentally, when the cell tries to copy its DNA or repair it, these cross-links physically block the process, causing the DNA strands to break, which ultimately triggers cell death.
Because they damage DNA so directly, does that lead to long-term risks too?
That's a really important point, yes. Because they cause such fundamental DNA damage, alkylating agents are known to increase the risk of secondary cancers, especially leukemias or myelodysplastic syndromes, sometimes years after the initial cancer treatment was successful.
So it's a trade-off.
It's a serious trade-off we accept to treat the primary cancer, but patients need to be aware of that long-term risk.
Let's zoom in on two big ones, cisplatin and cyclophosphamide. They have some notorious toxicities.
They do. Cisplatin is famous, or infamous, for three major dose-limiting toxicities: severe kidney damage, nephrotoxicity; nerve damage, peripheral neuropathy; and hearing loss, ototoxicity.
And kidney damage is a big one, right?
Mhm.
Requires specific precautions.
Huge. The nephrotoxicity can be profound. Standard practice involves aggressive hydration, giving lots of IV fluids before and after the cisplatin infusion, sometimes saline boluses too. The goal is to flush the drug and its metabolites through the kidneys quickly to prevent them from building up and damaging the renal tubules.
And avoid other kidney-damaging drugs at the same time.
Absolutely. You have to be very careful about co-administering drugs like aminoglycoside antibiotics. For cyclophosphamide, the classic toxicity is hemorrhagic cystitis.
Bleeding from the bladder.
Yes, severe inflammation and bleeding in the bladder lining caused by toxic metabolites concentrating in the urine. Again, the prevention is aggressive hydration, pushing fluids, sometimes up to 3 liters a day if the patient can tolerate it. And often we also give a protective drug called Mesna, which specifically binds to and neutralizes those toxic metabolites in the bladder.
Okay, the other big CCNS class mentioned is cytotoxic antibiotics, which sounds weird. Antibiotics for cancer.
Yeah, the name is a bit confusing. These aren't antibiotics used for infections. They were originally derived from microbes, but are used purely for their cytotoxic effects. The main group here are the anthracyclines.
Like doxorubicin, the red pill.
Exactly. Doxorubicin, daunorubicin. They're often reddish in color, hence the nickname. And the critical major toxicity associated with them is cardiotoxicity, heart damage.
Specifically, what kind of heart damage?
It can cause an irreversible cardiomyopathy, a weakening of the heart muscle that can lead to potentially fatal heart failure. And this risk is cumulative.
Cumulative, meaning it adds up over time.
Yes, the risk is directly related to the total lifetime dose of the anthracycline the patient receives. Each dose adds a bit more potential damage.
Why is the heart so vulnerable, and why is it cumulative?
It's thought that doxorubicin generates a lot of damaging free radicals inside heart muscle cells. These radicals damage cell membranes and DNA. Crucially, heart muscle cells don't repair or regenerate very well, and they lack some of the protective antioxidant enzymes other cells have. So the damage just accumulates with each exposure.
So you have to track the total dose very carefully.
Extremely carefully. Patients need baseline heart function tests like MUGA scans or echocardiograms before starting, and then periodic monitoring during treatment to check their ejection fraction, how well the heart is pumping. If it starts to drop significantly, you have to stop the drug or adjust the dose immediately.
And then there's bleomycin in this class, which targets the lungs instead.
Right. Bleomycin is different. Its dose-limiting toxicity is pulmonary fibrosis, scarring of the lungs, and pneumonitis, inflammation. This requires really careful monitoring of their breathing, listening for a dry cough, shortness of breath, often needing pulmonary function tests periodically. It's an insidious damage that can creep up.
Okay, so we've covered a lot of the broader cytotoxic drugs that hit rapidly dividing cells. But oncology is moving towards more precision, isn't it? Targeted therapy.
Definitely. This is a major shift. Targeted drugs like tyrosine kinase inhibitors, TKIs, and monoclonal antibodies, MABs, are designed differently. Instead of just poisoning any rapidly dividing cell, they go after specific molecules or pathways that are crucial for that particular cancer's growth or survival.
So the idea is to be more selective, Hit the cancer cells, spare the normal ones.
That's the goal, to minimize that collateral damage we see with traditional chemo.
And the classic example of this is imatinib, or Gleevec.
Absolutely. Gleevec really revolutionized treatment for chronic myeloid leukemia, CML. CML is caused by a specific genetic mistake, the Philadelphia chromosome, which creates a faulty, hyperactive enzyme called the BCA-able tyrosine kinase.
And that enzyme basically tells the cell to just keep dividing.
Constantly. It's stuck in the on position. Imatinib is designed to specifically block only that faulty BCA-able enzyme. It fits into the enzyme and turns it off. So it shuts down the cancer's main growth signal with far fewer side effects on normal cells compared to older treatments. It's incredibly precise.
We also see targeted drugs used to kind of starve the tumor. Angiogenesis inhibitors.
Right. Bevacizumab is a key example there. Tumors need a blood supply to grow beyond a certain tiny size. They send out signals, growth factors like VEGF, telling the body to grow new blood vessels into the tumor.
Angiogenesis.
Exactly. Bevacizumab blocks VEGF. It basically intercepts that signal so the tumor can't develop the new blood vessels it needs to get oxygen and nutrients. This can slow down the tumor's growth and potentially limit its ability to spread.
Okay. Now let's broaden out a bit to biologic response modifying drugs, or BRMs. These sound like they work with the body's own systems.
They do. BRMs, which are also called immunomodulating drugs, work by changing the patient's own immune response to fight the disease, usually cancer. It's based on the idea that a healthy immune system should recognize cancer cells as foreign or abnormal.
So how do BRMs help it do that?
They work in a few main ways. Some enhance the immune system's weapons, making immune cells better killers. Some have a direct toxic effect on the tumor cells themselves. And others modify the tumor's environment or biology, maybe making it harder for it to hide or spread.
This means we need a quick reminder of the immune system basics. Humoral versus cell-mediated.
Good point. Humoral immunity is mainly about B cells. When B cells get activated, they turn into plasma cells and pump out antibodies, those Y-shaped proteins that tag specific invaders or toxins for destruction.
Okay, antibodies.
Cell-mediated immunity involves T cells primarily, but also macrophages and natural killer, or NK cells. These cells are the direct attackers. They recognize infected cells or cancer cells and kill them directly. In cancer and transplant rejection, it's mostly the T cells and NK cells doing the heavy lifting.
Got it. So let's look at some BRMs that are used all the time in cancer care, often to help manage chemo side effects. The hematopoietic drugs, colony-stimulating factors.
Yes, CSFs are essential supportive care. Chemotherapy hammers the bone marrow, causing those low blood counts we talked about. CSFs help the bone marrow recover faster.
Like filgrastim.
Exactly. Filgrastim, also called GCSF, specifically stimulates the production of neutrophils, those key infection-fighting white blood cells. By shortening the period of severe neutropenia after chemo, it dramatically reduces the risk of life-threatening infections.
And epoetin alpha?
That one stimulates red blood cell production to combat chemo-induced anemia and fatigue. By using these CSFs, we can often keep patients on their planned chemo schedule and sometimes even use higher, more effective doses because the bone marrow recovers quicker.
Is there a crucial timing rule we need to know for filgrastim?
Absolutely. This is a major safety point, often tested. Filgrastim must not be given within 24 hours before chemotherapy or within 24 hours after chemotherapy.
Why is that?
Think about it. Chemo kills rapidly dividing cells. Filgrastim makes neutrophil precursors divide rapidly. If you give it right before chemo, you're essentially painting targets on those very cells you want to protect, making them more vulnerable to the chemo.
Ah, okay. That makes sense. You wait until the chemo's main killing phase is over.
Right. And you usually stop giving it once the neutrophil count, the ANC, recovers to a safe level, often considered above 10,000 cells per cubic millimeter.
Patients often report a specific side effect of filgrastim, don't they? Bone pain.
Yes. It's very common and can be quite intense. Because you're revving up the bone marrow so much, patients often feel feverish, achy, and have significant bone pain, usually manageable with standard pain relievers, but important to warn them about it.
Okay. Moving to other types of immunomodulators, interferons.
Interferons alpha, beta, gamma are copies of proteins our own body makes naturally. They have antiviral effects, some anti-tumor activity, and generally modulate the immune response.
How do they work against cancer?
They seem to hinder viral replication, which is relevant for some virus-linked cancers. But more broadly, they boost the killing power of NK cells and macrophages, key players in tumor surveillance.
And the main side effect people experience.
Almost universally, it's a really significant flu-like syndrome, chills, high fever, muscle aches, and especially profound fatigue. It can be dose-limiting, meaning so severe you have to lower the dose or stop the drug. Pre-medication with acetaminophen can sometimes help.
Next up, monoclonal antibodies, the MABs. We recognize these by the MAB at the end of the name. These are the really targeted ones, right?
Yes, these are engineered antibodies designed to bind to one very specific target, one specific antigen. For example, trastuzumab targets the HER2 protein found on some breast cancer cells.
But MABs aren't just for cancer.
No, definitely not. Drugs like adalimumab or infliximab target an inflammatory protein called TNF, tumor necrosis factor. Blocking TNF is incredibly effective for autoimmune diseases like rheumatoid arthritis or Crohn's disease.
Since these are powerful immune drugs, there must be significant safety concerns, especially around infection.
Huge concerns, especially with the ones that dampen inflammation, like the TNF inhibitors. They carry black box warnings because they significantly increase the risk of serious infections. This includes reactivating latent tuberculosis or hepatitis B.
So patients need screening beforehand.
Mandatory screening for TB and Hep B before starting drugs like infliximab. And infusion reactions are also common with many MABs allergic type responses during the infusion. So pre-medication with antihistamines like diphenhydramine and acetaminophen is often standard practice.
And trastuzumab, the breast cancer MAB, has a specific warning too.
Yes, trastuzumab carries a risk of heart problems, specifically ventricular dysfunction and heart failure. Similar to doxorubicin in that regard, so cardiac monitoring is essential.
Okay, finally in this section, the interleukins, like aldesleukin. And this one comes with a really scary potential toxicity, capillary leak syndrome.
Yes, aldesleukin is a recombinant form of interleukin-2, IL-2. Its job is to powerfully stimulate T cells, causing them to multiply into highly activated cancer-killing cells called LAK cells, lymphokine-activated killer cells.
But that intense immune activation causes problems.
It causes capillary leak syndrome, or CLS. This is a critical toxicity.
Can you explain what happens in CLS? It sounds bad.
It is. Essentially, the capillaries, the tiniest blood vessels, become leaky all over the body. The junctions between the endothelial cells lining the vessels loosen up. Fluid, protein, albumin. Everything starts leaking out of the bloodstream and into the surrounding tissues.
So fluid shifts out of the vessels.
Massively. Patients can gain huge amounts of weight very quickly, 20, 30 pounds of fluid in just a day or two. It's called third spacing. But the devastating paradox is, while their tissues are waterlogged, their blood vessels become depleted of volume. Severe low blood pressure, shock, respiratory distress from fluid leaking into the lungs, pulmonary edema, and heart failure. It can be fatal if not recognized and treated immediately.
How is it managed?
First, you have to recognize it immediately and stop the aldesleukin. Then it requires intensive care support fluids carefully managed, sometimes drugs to support blood pressure, maybe albumin to try and pull fluid back into the vessels. It's reversible if caught early, but it's a major high-alert toxicity.
That discussion of immune modulation flows really well into part 3.
Yeah.
Here, the focus shifts away from attacking cancer towards, well, deliberately suppressing the immune system. We're talking immunosuppressants now.
Exactly. These are crucial drugs for preventing organ transplant rejection and for managing severe autoimmune diseases where the body is mistakenly attacking itself.
And the main goal is to selectively target.
Primarily T lymphocytes. T cells are the main drivers of graft rejection and involved in many autoimmune conditions. So the goal is to suppress those specific cell lines. And a key difference from chemo is that for transplant patients especially, this immunosuppression is usually lifelong.
Lifelong suppression. That brings its own set of challenges. What are the main drug classes used here?
The foundation drugs are usually the calcineurin inhibitors, that's cyclosporine and tacrolimus. Also, antimetabolites like azathioprine and mycophenolate mofetil are very important. And sometimes biologics like basiliximab are used, especially around the time of transplant.
Let's focus on cyclosporine and tacrolimus first. They have a reputation for being tricky to manage, right? Narrow therapeutic window.
Extremely narrow. That means the dose needed for the drug to work effectively is very close to the dose that causes serious toxicity.
How do they work?
They inhibit calcineurin, which is an enzyme needed for T cell activation and proliferation, so they stop the T cells from getting the go signal.
And managing that narrow window means?
Frequent blood level monitoring.
Yeah.
Specifically, trough levels the lowest concentration of the drug right before the next dose is due. If the trough level is too low, the patient risks rejecting their transplant. If it's too high, they risk serious kidney damage. nephrotoxicity, and liver damage, hepatotoxicity. It's a constant balancing act.
And there's that crucial point about different cyclosporine formulations, Sandimmune versus a Nurol or Gengraph. They can't just be swapped, can they?
Absolutely not. This is a huge medication safety issue. The original formulation, Sandimmune, has really variable and often poor absorption from the gut. The newer modified versions, like Nurol and Gengraph, were developed with a different delivery system, microemulsion, that makes them absorb much better and more consistently.
So switching from Sandimmune to Nurol at the same milligram dose would
Lead to a sudden, massive increase in the amount of drug actually getting into the bloodstream. This could cause acute severe toxicity kidney failure, dangerously high blood pressure. They are not bioequivalent. You can never substitute them for each other without specific prescriber guidance, and likely significant dose adjustments.
really critical point. What about the antimetabolites used for immunosuppression, like azathioprine?
Azathioprine is often used for rejection prevention and also for things like severe RA or Crohn's. It's actually a prodrug. It gets converted in the body to its active form, which then interferes with DNA synthesis, particularly in lymphocytes.
Is there anything specific to watch for with azathioprine?
Yes, there's a genetic factor. Some people have low levels of an enzyme called TPMT thiopurine methyltransferase, which is needed to break down azathioprine properly. If you have low TPMT activity and take a standard dose, the drug builds up much faster and can cause rapid, severe bone marrow suppression.
So ideally, patients should be tested for TPMT activity first.
Ideally, yes. Genetic testing for TPMT status is becoming more common before starting azathioprine to guide dosing safely. Other risks include pancreatitis and liver toxicity.
Since these patients are suppressed long-term, what are the big overarching risks they face?
Two main things consistently. First, significantly increased risk of infections, not just common colds, but serious opportunistic infections caused by organisms that wouldn't normally harm someone with a healthy immune system. Think fungi, specific viruses like CMV, etc.
And the second risk?
An increased long-term risk of developing certain types of cancers, particularly lymphomas and skin cancers. The suppressed immune system is less able to patrol for and eliminate cancerous cells.
So patient education must include
Strict infection prevention, meticulous hand hygiene, avoiding sick contacts in large crowds, ensuring food safety. Also, critically, avoiding live vaccines, as their suppressed immune system could actually get the disease from the vaccine. And for the cancer risk, vigilant sun protection, sunscreen, hats, protective clothing is essential due to the increased skin cancer risk.
Okay, let's pivot now to the other side of the coin. Immunizing drugs. Boosting immunity, not suppressing it. We need to be really clear on active versus passive immunity.
Absolutely fundamental distinction. Active immunization is what we usually think of as vaccination. You administer an antigen, a killed or weakened virus or bacterium, or just a piece of one, like in toxoids or subunit vaccines. Examples are MMR, DTaP, HPV vaccine.
And the goal is
To trigger the person's own immune system to respond. Specifically, the humoral system B cells produce antibodies against that antigen, and crucially, memory cells are created. This provides long-lasting, sometimes lifelong, protection, but it requires the person to have a functioning immune system capable of mounting that response.
okay. So what's passive immunization then?
Passive immunization is like getting a temporary loan of someone else's immunity. You directly inject preformed antibodies called immunoglobulins that were harvested from donated human plasma or sometimes from animals.
So you skip the part where the patient makes their own antibodies.
Exactly. It completely bypasses the patient's own immune response. This gives immediate, rapid protection. But because the patient didn't make the antibodies themselves, the protection is temporary. It only lasts as long as those injected antibodies circulate before being naturally broken down, usually weeks to months.
When would you use passive immunity?
Two main situations. One, if the patient is immunocompromised and can't mount their own effective immune response to a vaccine. Two, if someone has already been exposed to a dangerous pathogen and needs protection right now, faster than a vaccine could work. Think rabies exposure, tetanus exposure if unvaccinated, or snake bites, where you give antivenin, which is animal-derived antibodies. Rogum for Rh-negative mothers is another example of passive immunity.
Got it. And lastly here, there's a common medication error potential with the diphtheria, tetanus, pertussis vaccines, DTaP versus Tdap.
Yes, this happens, unfortunately. The key is the capitalization. DTaP with the capital D and P is the formulation for the primary childhood immunization series given to infants and young children up to age 6. It contains higher concentrations of the diphtheria and pertussis components.
Okay, DTaP, higher dose for kids.
Right. Tdap lowercase d and p is the booster vaccine formulation used for adolescents and adults, age 7 and up. It contains reduced amounts of the diphtheria and pertussis antigens.
And the air.
Giving Tdap to an infant instead of DTaP. Because it has less antigen, the infant won't develop adequate immunity, leaving them unprotected, or sometimes giving DTaP to an older child or adult, which could cause more local reactions due to the higher antigen load. So, checking the exact formulation against the patient's age is critical.
We've covered a huge amount of ground chemo, biologics, immunosuppressants, vaccines. Part 4 is where we need to tie it all together from a nursing perspective. What are the universal safety issues that cut across these powerful drug classes?
The core challenge, the central nursing problem, really stems from the fact that many of these drugs, especially chemotherapy, but also some immunomodulators, aren't perfectly selective. They target rapidly dividing cells. Yes, that includes cancer cells, but it also includes our own healthy, rapidly dividing cells.
Like where?
The lining of the gastrointestinal tract, mouth to anus, hair follicles, reproductive cells, sperm and eggs, and critically, the cells in the bone marrow that produce our blood components.
And that damage to the bone marrow, that leads to the biggest universal side effect, right? Myelosuppression.
Myelosuppression, or bone marrow suppression, is probably the single most important dose-limiting toxicity for many of these agents. It means the bone marrow isn't producing enough blood cells. This leads to 3 major problems, often called the counts.
Okay, what are they?
First, leukopenia, specifically neutropenia low neutrophils, the main infection-fighting white blood cells. This means a drastically increased risk of serious, potentially fatal infections. Second, anemia low red blood cells, leading to fatigue, shortness of breath, hypoxia. And third, thrombocytopenia low platelets, which are needed for clotting, leading to a high risk of bleeding.
And we need to know when the counts are likely to be at their lowest point.
Absolutely. That lowest point is called the nadir. The timing varies depending on the specific drug, but it typically occurs somewhere between 10 and 28 days after a chemotherapy dose. Knowing the expected nadir helps anticipate when the patient is most vulnerable.
And clinically, what level of neutropenia is really dangerous?
Severe neutropenia is usually defined as an absolute neutrophil count, or ANC, falling below 500 cells per cubic millimeter. That's a medical emergency due to the profound infection risk.
So nursing actions flow directly from these risks.
Directly. Meticulous assessment is key. You're constantly monitoring for the earliest signs of infection. And remember, in a neutropenic patient, the classic signs like high fever or pus might be absent. Even a low-grade fever, say 100.4 Fahrenheit or 38 Celsius, could signal a serious infection and needs immediate reporting and workup.
What about monitoring for bleeding?
Looking for tiny bruises, petechia, larger bruises, ecchymosis, any blood in the stool or urine, bleeding gums, and implementing bleeding precautions.
Which includes specific restrictions on procedures.
Yes, if platelets are very low, thrombocytopenia, you need to protect the patient from any trauma that could cause bleeding. That means avoiding intramuscular injections, applying prolonged pressure after any needle stick or IV removal, and critically, no rectal temperature suppositories or enemas.
Why no rectal wrap?
The rectal mucosa is fragile and has lots of blood vessels. Inserting a thermometer or suppository can easily cause micro tears. In a patient who can't fight infection and can't clot properly, this can create a portal for bacteria to enter the bloodstream, sepsis, and a site for potentially uncontrolled hemorrhage. Oral or axillary temperatures are much safer.
Okay. Another major administration risk, especially with certain chemo drugs, is extravasation.
Yes. Extravasation is when a vesicant drug, one that can cause severe tissue damage, blistering, and necrosis, if it leaks out of the vein, leaks into the surrounding tissue.
Which drugs are common vesicants?
Doxorubicin, the anthracyclines, and the vinca alkaloids like vincristine are classic examples, but there are others.
Prevention is key here.
Absolutely paramount. Whenever possible, vesicant should be given through a central venous access device like a port or PICC line, rather than a peripheral IV, as these are more secure. If a peripheral IV must be used, it needs to be assessed constantly, like every hour during the infusion for any signs of redness, swelling, pain, or leakage.
And if you suspect extravasation is happening, what's the immediate action?
The protocol is very specific and must be followed instantly. 1. ESTA, stop the infusion immediately. 2. Leave the 5-FA catheter in place initially. Do not pull it out right away. 3. Try to gently aspirate any residual drug back out through the catheter. 4. Then consult the specific institutional protocol for that drug. There are often specific chemical antidotes that need to be administered, sometimes injected through that same catheter or around the site.
Antidotes. Like what?
For example, hyaluronidase is often used for vinca alkaloid or taxane extravasation. Sodium thiosulfate might be used for meclorethamine. The key is knowing the protocol and acting fast to minimize the tissue destruction, which can be severe enough to require surgery or even cause limb loss.
We also need to discuss the impact on fertility and pregnancy. These drugs hit reproductive cells hard.
They do, because germ cells, sperm and egg precursors, are rapidly dividing. They're very sensitive to cytotoxic drugs. This can lead to irreversible sterility in males and premature menopause or infertility in females.
And the risk during pregnancy.
These drugs are potent teratogens. They can cause miscarriage, stillbirth, or severe birth defects and genetic abnormalities in a developing fetus.
So contraception is essential.
Absolutely mandatory for patients of reproductive potential, both male and female, during treatment and often for a significant period after treatment ends. How long depends on the specific drug, its half-life, and potential for long-term genetic damage. It could be anywhere from 8 weeks to potentially 2 years or more after the last dose.
And counseling about fertility preservation before starting therapy.
Crucial. Male patients should be offered sperm banking. Female patients should be counseled on options like egg freezing or embryo cryopreservation. This needs to happen before the first dose of potentially sterilizing chemotherapy because the damage can happen quickly.
Okay, wrapping up this synthesis. Targeted symptom management for those common side effects. Stomatitis mucositis first, the sore mouth and gut.
Right, from damage to the GI lining. The key is gentle care and avoiding irritation. No harsh mouthwashes, especially alcohol-based ones. No tobacco. Avoid spicy, acidic, rough, or very hot-cold foods. Use a super soft toothbrush. Frequent rinses with plain saline or baking soda solution can be soothing and help keep the mouth clean.
Nausea and vomiting. Some drugs, like cisplatin, are notorious for this.
Extremely common and can be debilitating. The absolute rule is prophylaxis. Give antiemetic drugs before the chemotherapy starts, usually 30 to 60 minutes prior. Don't wait for the patient to feel sick. Often, antiemetics need to be continued on a regular schedule for 24-72 hours or even longer after chemo, depending on the regimen's emetic potential. Breaking that cycle of nausea is key.
Alopecia, hair loss.
Very distressing for many patients. It's important to prepare them before therapy starts that hair loss is likely with certain drugs. Discuss options like wigs, scarves, caps. Reassure them that hair usually regrows after treatment finishes, though the texture or color might be different. Assess how the patient feels about it and offer support.
And finally, kidney protection, nephrotoxicity.
We talked about cisplatin, but other drugs can be hard on the kidneys too. Monitoring kidney function tests, BUN and creatinine is standard. And encouraging good fluid intake, that aggressive hydration we mentioned, maybe 2-3 liters a day if their heart can handle it, is vital not just for cisplatin, but also for drugs like high-dose methotrexate, and importantly for cyclophosphamide to prevent that hemorrhagic cystitis. Flushing the kidneys helps clear toxic metabolites.
Hashtag tag 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 outro.
Wow. Okay, we have covered an incredible amount of complex information today. We went through the cytotoxic landscape, those CCS and CCNSS drugs, explored the more precise world of targeted therapies and biologics, and really nailed down the crucial differences between immunosuppression for transplants or autoimmunity and immunization to prevent disease.
And I think the major takeaway, the thread connecting all of this, is how these powerful drugs impact rapidly dividing cells. Whether you're trying to kill cancer, modulate the immune system, or even stimulate bone marrow recovery with something like filgrastim, the potential for collateral damage, especially bone marrow suppression and GI toxicity, is almost always there.
Right. So understanding the drug class, its mechanism, whether it's cell cycle specific or not, that's absolutely essential for anticipating the risks and keeping patients safe. It requires critical thinking, not just memorization.
So as you, the learner, put all this together, here's something to maybe think about further. Consider a drug like methotrexate again. We talk about it as a high-dose cancer killer, right?
Mm-hmm.
But it's also used in tiny weekly doses to manage autoimmune diseases like rheumatoid arthritis. How does seeing that same molecule used across such a vast spectrum, from aggressive cell killing to very careful immune modulation, how does that change how you think about pharmacology? And how does it underscore the absolute life or death importance of getting the dose, the schedule, and the patient teaching exactly right?
That clinical nuance, understanding that context and application, is really what defines expert practice.
We really hope this deep dive has helped make this challenging unit feel more manageable and clinically relevant for you. Thank you for joining us. Keep asking those questions, stay curious, and above all, stay safe out there.